My name is Fehra Saeed. I'm one of the consultant fetal medicine obstetrician and gynecologists at BARS Health, London. I'm also working as honorary clinical senior lecturer at BARS in London School of Medicine at Queen Mary University of London. The topic of today's talk is hypertension in pregnancy. It's a very important topic still even in developed country, because still we see it as a very common cause of maternal death. And most of the death happen because of the inadequate treatment of hypertension leading to intracranial hemorrhage. The definition is a sustained blood pressure of 140/90 or greater, 6 hours apart, or a single reading of 160/110. There are some risk factors where we predict hypertension in those women. So if this is the first pregnancy with high body mass index or history of preeclampsia in previous pregnancy, either this woman is very young, less than 18, or a little bit on the advanced maternal age, more than 40, that increases the risk of having hypertension in pregnancy. If woman has got a family history of hypertension and preeclampsia, especially mother or sister having preeclampsia, it increases her chance of having this problem as well. History of chronic hypertension, chronic renal disease, connective tissue disorders, antiphospholipid antibody, or any kind of thrombophilia, diabetes, these medical disorders increases the risk of preeclampsia in the woman. Multiple pregnancy, because it's a placental dysfunction disorder, multiple pregnancy has got larger placenta, therefore the risk of having preeclampsia is higher. There is a literature suggesting that male partners whose previous partners have preeclampsia can lead to preeclampsia in their new partners, and therefore this paternal origin of preeclampsia has also been discussed in literature. There has been thousands of different theories about why preeclampsia happens. One is vasospasm, degree of some inadequate hemostasis, some kind of imbalance between different prostanoids, endothelial-derived factor, peroxide, antioxidant free radical. But the most popular theory is the inadequate uterine vessel, where maternal vascular response to trophoblastic mediated vascular changes is not enough, and they are unable to penetrate the arteries. So spiral arteries in the uterine vasculature, if they cannot be penetrated by these trophoblastic tissue, and if they retain their elasticity and smooth muscles, therefore are responsive to all kind of vasopressin in maternal blood, and therefore it leads to problem with number one, leading to the growth retardation of the baby, because vessels are constricting in response to maternal vasopressin. It should be a free flow around the baby, and it also leads to preeclampsia. These are the continuum of the similar placental disorder, IUGR and preeclampsia. There are different kind of hypertension one may encounter. Chronic hypertension means woman has already had blood pressure before she started pregnancy, or she started pregnancy normotensive and developed a transient gestational hypertension just for during pregnancy. And preeclampsia and eclampsia is another entity where you have high blood pressure as well as proteinuria of significant amount of to be classified as preeclampsia. Sometimes chronic hypertension patient, as I mentioned, can develop a superimposed preeclampsia. So when we say pre-existing hypertension or chronic hypertension, they exist before pregnancy. Their systolic blood pressure was 140, diastolic more than 90, or both, and they present usually before 20 weeks of gestation. And causes are for any other causes for any adult associated blood pressure, like essential hypertension, secondary to renal artery stenosis, pheochromocytoma, etc. The treatment for these chronic hypertension is oral methyl dopa, which is the most longest tested drug, and labetalol, which is being used in the last 1 decade. Gestational hypertensions are mild hypertension without proteinuria and develop after 20 weeks of gestation, and it resolves by 12 weeks postpartum. But sometimes they can progress into preeclampsia. The choices of antihypertensive will remain the same. Preeclampsia is a very specific entity where you have a multi-system disorder. It started with high blood pressure and proteinuria after 20 weeks, and then involves most of the organs, namely kidneys, liver, and can lead to bleeding in the brain as well. So what are the pathophysiological changes which happen in different systems of the body when you have preeclampsia? The cardiovascular effect include obviously hypertension itself, increased cardiac output, and increased systemic vascular resistance. Current theories are that actually cardiovascular system of the mother is responsible to have preeclampsia, but we're just playing around with these theories to decide which has caused the other problem. The hematological changes are the volume contraction or hypovolemia. So what happens in preeclampsia that you have endothelial damage, and due to these damage, the vessels become leaky, and all the fluids from the vasculature from the vessels goes into the third space. So therefore, these women they appear more swollen on their face, on their feet, on their hand, and sometimes this fluid goes out quite a bit into dangerous territory. That means it can lead to pulmonary edema. So in hematological effect, you have volume contraction, hypovolemia because of the leakage of the fluid outside the vessel, elevated hematocrit as a result, and thrombocytopenia happens because if there's an endothelial damage, the platelets will go down. There is a microangiopathic hemolytic anemia, as I said, third space of fluid, and low oncotic pressure because the protein go out as well, and therefore you see these protein in the urine. Neurological effect is due to cerebral edema causing headache, hyperreflexia, and seizures, which are known as eclampsia. Pulmonary effect, as I mentioned, due to the capillary leak and reduced colloid osmotic pressure, these women have a high risk of developing pulmonary edema. Therefore, be very careful when you're loading with IV fluid, treating sepsis or any other disease. Make sure these pregnant ladies don't have preeclampsia. Pathophysiological changes in renal system are decreased glomerular filtration rate, glomerular endotheliosis, proteinuria, oliguria because kidneys are not perfused adequately, leading to acute tubular necrosis. Now, the baby inside have similar kind of exposure to the problem. The placenta is not healthy, therefore there's a risk of placental abruption. The flow of the blood, the oxygen and the glucose is not enough to the baby, therefore babies develop growth restriction. And as I mentioned, when babies are not getting good oxygen and glucose, they start compromising their system one by one. And when it comes to the kidneys, they stop producing adequate amount of urine, which is indicated on the ultrasound by looking at the fluid level. And if there is oligohydramnios, we start thinking about the effect of preeclampsia on babies as well. It can cause obviously distress if babies don't have any reserve because of the IUGR, and it can lead to intrauterine death if the perfusion stops from the placenta. Now, patient may present with headache, visual symptoms, epigastric pain, and right upper quadrant pain. However, they're completely asymptomatic. And these are the most dangerous patients because they don't have any symptoms and they have the most highest level of blood pressures. Signs of preeclampsia include obviously hypertension, non-dependent edema on hand and face, brisk reflexes, clonus of more than 3 beats, and if this baby is affected as well, you will see IUGR. Therefore, the fundal height will be less than the expected gestational age. So the implication are intracranial hemorrhage, placental abruption, eclampsia. HELP is another specific entity of preeclampsia, and it is hemolysis, elevated liver enzymes, and low platelet. And that would be dangerous. When one woman develops HELP, you need to quickly deliver the baby and resuscitate the woman with whatever she needs, because she may go into DIC and renal failure very easily. Pulmonary edema and ARDS happen because of the leaky vessels and low oncotic pressure. Therefore, there is a very specific protocol to manage the fluid of these women while they are hospitalized. Fetal complication, as I said, IUGR, abruption, and IUD. Sometimes because of severe complication of preeclampsia, we need to deliver these babies preterm. Therefore, the iatrogenic preterm is another complication of preeclampsia. Severe preeclampsia is when you have 160, 110 or more blood pressure with proteinuria of 30 milligram per millimole in PCR, which is the spot check on the urine. So urine stands for urine protein creatinine ratio. If it's more than 30 milligram, that means she has significant proteinuria. Therefore, you can diagnose this woman as a case of preeclampsia. If she has a blood pressure of 140/90 with one of the following symptoms, then you can still call it preeclampsia. For example, a woman comes with 140/90 blood pressure with blurring of vision and right-sided upper quadrant pain and vomiting or liver tenderness or HELP syndrome or severe headache, you still call it severe preeclampsia. So any woman with 140/90 blood pressure with severe headache is severe preeclampsia. Sometimes you see these women in community where there are no help available to deal with these complicated cases. Therefore, you have to transfer them to hospital who are equipped with the facilities to deal with these patients. These patients may need ITU sometimes if the complications are present. So you transfer them to a kind of tertiary care center if possible, or a center which has got expertise available to deal with preeclampsia. Do not leave patients unattended because they would have fit if they have severe preeclampsia. In case of fit, just make them in the recovery position and wait for fit to disappear, because most of the fits are self-limiting. Whenever you are transferring the patient, transfer the patient with adequate information. We use SBAR handover here, and therefore you can use a similar SBAR handover, which is situation, background, assessment, and recommendation. For example, I would say, I'm transferring a patient who is 32 weeks pregnant with severe preeclampsia. Background is this is her first baby, no antenatal care, coming today with severe headache. Her blood levels are fine. Her background is she might have one cesarean section in the past. So these are the obstetric and medical background. And assessment, currently she has got A, B, C, D, E. She has got airway intact. She's breathing. Her blood pressure, pulse, temperature is this. She's passing urine. She's not fitting, but she's complaining of severe headache. And my recommendations are she would need to be in the tertiary care center and to be started on antihypertensive medication and maybe to do something to prevent the seizures. Severe hypertension is an obstetric emergency, and systolic blood pressure poses the greatest risk. So call for help, and these help are senior obstetrician, senior anesthetist, and you have to do ABC while the team is on their way. As a medical student, whenever you see a patient and you're suspecting preeclampsia, you have to ask signs and symptoms of preeclampsia, like headache, right upper quadrant pain, or blurring of vision, swelling. Ask past medical history if she has got a chronic hypertension, or the medical disorders I've just mentioned in my previous slide, which increases her risk of having preeclampsia. Past family history, mother had preeclampsia, sister had preeclampsia. Past obstetric history, in a previous pregnancy she had preeclampsia, therefore she has a high risk of having it again. Medication, if she is on any medication, any allergies, you don't want to prescribe any medication unless you know that she's not allergic to those. And assess for the hypertension and pregnancy risk factor, as we discussed in last slides. Do a blood pressure pulse. Respiratory rate is a very sensitive indicator of women being unwell. Auscultate, try and exclude pulmonary edema. Auscultate abdomen, see if she's not having epigastric and right upper quadrant pain, which could be a sign of HELLP syndrome. And check her reflexes. If they are very brisk, very jumpy, you know that this patient has got a problem of preeclampsia, which is getting worse. And do measure the baby to find out if the baby is well grown or not. What bloods you need to do? You need to do the full blood count. Obviously, you need to see the hemoglobin to see whether it's enough for a healthy pregnancy. You have to see the platelet count to exclude thrombocytopenia. You need to see the renal function test to check the creatinine, and liver function test to check the ALT, because if she's developing HELLP syndrome, ALT will go higher. Coagulation to exclude GIC, and urine protein to confirm that she's preeclamptic. If woman starts to fit in front of you, you go and call for assistance first, because if you start dealing with the patient, then you can't leave her. So go and ask for help, make her go left lateral, make sure she has got her airway maintained, give her oxygen if you have, maintain IV line, take bloods for the blood test we have just mentioned. Ideally in the hospital, if anybody fits, then we call it eclampsia until proven otherwise. Unless she is non-epileptic, then the medications are completely different. The drug of choice for eclamptic fit is magnesium sulfate. Most of the fits are self-limiting. If you don't have medication, keep the woman in left lateral until the fit resolves. And during the acute event, the mother takes the precedence and you deliver the baby to actually assist the mother to terminate the pregnancy, because that's the only thing, this is the only ultimate treatment for preeclampsia and eclampsia. So management of hypertension, you have to have close monitoring. You have to have very vigilant, regular blood pressure monitoring depending upon the severity. Carry on asking sign and symptom of preeclampsia. And if you're seeing them in the clinic, do plan fetal growth, do plan CTG if you have a concern about baby's movement, and do weekly or 2 weekly blood tests depending upon the severity of blood pressure. You don't deliver them once you have diagnosed preeclampsia. If you have diagnosed preeclampsia, you have to understand what is the severity, what is the gestational age, how is the baby doing, how is the mother doing, and based on these information, you make a decision to carry on or terminate the pregnancy. Definitive treatment, as I said, is delivery. Antihypertensive treatment is to prevent the complication of bleeding and a stroke. The choice of therapy in emergency is IV labetalol, IV hydralazine, or nifadipine of slow release. Don't give any nifadipine fast acting, which can lead to hypertension and cardiac event. Long-term oral medication are oral methyl dopa and labetalol. Management of severe preeclampsia in obstetric unit. For example, somebody has got 160, 110 blood pressure and you know it's preeclampsia. You stabilize them, control blood pressure using IV medication, monitor them regularly, and then plan a delivery. And think about giving prophylactic magnesium sulfate to prevent fits from happening. Eclampsia is generalized seizures. 50% of eclampsia occurs prior to delivery. They are self-limiting and usually last less than 4 minutes. The treatment is magnesium sulfate. You don't have to remember these numbers, but obstetricians, they remember these numbers and they just go and give 4 to 6 grams of bolus as a start dose and then maintain it as 1 to 2 grams per hour. This is a very dangerous drug with a very narrow therapeutic index. Therefore, you have to monitor these mothers very closely for respiratory rate, because this is a respiratory depressor. We need to monitor deep tendons, reflex, and urine output. We also can send magnesium sulfate levels to check that it's not going towards the toxic level. To monitor the toxicity, respiratory rate has to be more than 12. Deep tendon reflex should be present. If it is not detectable, then there is a problem. If respiratory rate is less than 12, then there's a problem. And if patient is feeling dizzy and has altered sensorium, then there is a problem. Urine output has to be 100 ml every 4 hours. So in 1 hour, if it's less than 25, there is a problem. So you need to know that the antidote of this important medication, which is calcium gluconate, is present in most of the labor ward. So in conclusion, hypertension in pregnancy can kill. Severe preeclampsia is an obstetric emergency. Early recognition can save life. Once recognized, high blood pressure should be controlled to prevent its complication. Thank you very much for your attention.